Oops. Oh, unmute yourself. There. That's okay. There you go.
Okay.
Okay. There we go.
Perfect. All right, great. Well, thank you, Steve. And first, I want to hope that all of you have a happy holiday. I know it's crazy. I want you all to stay safe and try to have a little fun. I think that's what we all want to do. As Steve said, I'm Paula Sotier. I'm owner of CarePatrol Baltimore. We cover most of Baltimore County, all of Baltimore City and Hartford County. CarePatrol helps seniors find safe living options at no charge to the client, typically for assisted living and memory care. The most important thing is we are local and hands-on. Our process is that we understand the seniors' clinical needs today and the future. We want to know what they like, where they want to live, and their financial capabilities. And then a client last year called me a matchmaker. And the reason she said that is because we match the safe communities with the client's needs. We're able to be successful since we understand the community's clinical capabilities. We know their staffing levels. We know what amenities they have. And then we learn about the quality issues actually by reviewing the state survey. Since CarePatrol places so many clients, we have a real life experience with understanding all the care capabilities for our clients. You know, even in the pandemic, we have been able to arrange virtual tours and in-person tours, although the last couple of weeks it's been a little bit challenging. We assist the seniors or their family through the whole process until they are placed. You know, I'm really lucky to be part of the CarePatrol team of 7 franchises that covers all of Maryland, DC, and part of Virginia. We have placed over 2,800 clients in 950 communities. I'm actually very excited to hear about Theresa, since preventing falls for seniors, especially during the winter, is such a high priority. Thanks, Steve.
Great. And yeah, so we've got in the little Brady Bunch windows here, we've got Bonnie Danker, who is Howard and Montgomery County. We've got Robin Edwards, who's Northern Virginia. Bonnie Elliott, who's Central Maryland and Loudoun County, Virginia. Cindy Evans, who's Baltimore and Annapolis corridor. Amy and Gary Fager, who's Delmarva. And Charles Picard is Prince George's. And you just heard from Paula, who covers Baltimore. So thanks you all for putting this together, and thanks for inviting me to be a panelist. I get to learn new stuff every time I get to do this little podium job. So let's see. So without further ado, let's bring on Theresa, our guest today. And for those of you who don't, and Theresa, I've intentionally, excuse me, I've intentionally not been trying to pronounce your last name because I want to hear it come out of your mouth before it comes out of mine.
Thanks, Steve. It's pronounced Giuntini, like the month of June.
Giuntini. So, I would have not said it that way. Okay.
Yep. So, my husband is first generation Italian. So
great.
So
Theresa Giuntini, she's a doctor of physical therapy with board certifications in geriatrics, and she works with Fox Rehab. So welcome, Theresa. And me and the rest of the CarePatrol team, we're going to dive behind the curtains for your presentation. But I want to remind the audience that we really hope that they type in questions and feel free to throw out any questions or comments throughout the presentation and at the end there. But we're really charged up to gain some knowledge and wisdom. And I'm glad Paula brought up fall prevention on this day when we've got a few snow flurries, because this really is the season to fall, is when the sidewalks and everything get slippery.
Great. All right. Well, thank you so much, Steve, for hosting, and I want to thank CarePatrol for inviting me to come onto this platform and to give everyone a little bit of information about falls and the prevention of falls. So as Steve said, feel free. He's going to be keeping track of all of your questions. So type them in as I speak, and I will answer them as I go along. So you don't have to wait until the end. So please speak up, raise your hand in the format there, and we can make this very interactive. But as Steve said, I am a physical therapist, and I've always had a passion for working with older adults. And so 5 years ago, when I came across Fox Rehab, it was the perfect combination of working with older adults and doing it in an outpatient model. We bill Medicare Part B, but we do it in patients' homes. So it was just kind of blended everything perfectly. The older adults in the homes under Medicare Part B, which we are all over. We're in 23 states right now. We cover all of Maryland, and pretty much wherever you are living, I'm sure we are there. But we do have PT, OT, and speech. So we're not home health therapists in the fact that we don't have nursing, we don't have the aides. That's where a lot of you come in handy, and you are our resources out there in the community. But we do have PT, OT, and speech. And so lots of what we do is what I'm going to talk about. So I just wanted to share my screen here and pull up a PowerPoint. Let's see. Do you all see the big orange? We like orange at Fox.
Looks
okay,
good.
Perfect. All right. So this talk, we are, let's see here, fall prevention. First, I'm just going to start off with some statistics about falls, a little bit of background about, why are we talking about this? Everybody knows people that have fallen, you yourself might have fallen, and why is this such an important topic? But that you can see there some of the stats that I have on this slide, but also I wanted to bring up some other stats that are pretty startling, that here it says here, one second every day someone's falling. But one of the myths about falls is that they're happening when you're out in the community or at nighttime on your way to the bathroom. And when in actual reality, the evidence shows that 80% of falls are occurring indoors in someone's home, in their home during the daytime. So that's not what you would probably think as 80% of all falls, but that is when most falls are happening, and just as someone goes about their daily life in their home during the day. And every year, more than 1.6 million older adults are going to the emergency room as a result of a fall. So, and with that, 30% of those people are having moderate to severe injuries. And so that's where it's so important, because with those injuries, the number one cause there of hip fractures is falling. And in fact, 95% of all hip fractures are caused by a fall. And not to be morbid, but just evidence that 25% of people that fall and break their hip are actually going to die within a year. So the as you're older, the prevalence of mortality with a hip fracture is exponentially increased. But that's kind of a startling statistic, and that's straight off the Medicare.gov website. So kind of with that, not to be morbid, but just some of the statistics of why it's so important to talk about this topic. And then with falls, that they're often, they're basically why we're talking about this is that the good news is that 2/3 of all falls are completely preventable. So, but there are some that obviously with there's a third of those out there that you can't do anything about. But hey, take that 2/3 and let's talk about some of the risk factors and some of the things that we can do to prevent the falls, so that we are not just another statistic in there with all the falling. If you read the little description of some of the things that we're going to be talking about today, I just kind of wanted to highlight the fear of falling, and how fear of falling is actually an evidence kind of proven factor that increases your risk of falling. So if you're somebody who is extremely fearful of falling, you're actually going to be more likely to fall. I can only liken it to a situation that happened a few years ago. We were living out in Colorado, and they have these big open lakes that they get the Zambonis and they create them into a big ice skating ring right there in a big open lake. So I brought my kids to this lake to go ice skating, and we had with us that winter a international student from Mexico who was living with us. And so we went, we thought it'd be great fun. Well, as you can imagine, ice skating on an open lake, there's no hand railings, there's no walls, there's nothing to protect you from just the ice and the blades on your skate. So I had chosen at the beginning of this, I'm going to watch. I am not putting on skates. I'm not a good ice skater inside holding onto things. I'm definitely not going to do this in a lake out in the middle of nowhere. But the younger international student from Mexico decided this might be a great thing to do, so she could write home about it. So second she stepped out onto the ice, first time she fell. And so the rest of the day, well, it was only a couple hours that we were out there, but she decided she's going to sit on the sidelines and watch everybody. So as she and I sat and watched, I don't know, probably a few hundred people in this giant lake out there skating, having a great time. One by one, though, we were sitting at the entrance where people would walk down these little steps to get onto the ice. So many people would get, just like she did, you first get out there and you're not used to the slippery, and you just fall. So we actually saw, sadly, 3 different EMS calls where people were, hurt themselves, hit their head, hauled away on a, stretcher. Thankfully, nobody was unconscious or anything, but just the likelihood of falling when you're in this situation walking ice. At one point, she turns to me and she says, "This is what Americans do for fun?" She's watching everybody walk away or getting hauled off and falling. But I was, just that, if you can take that situation and just walking on ice and how careful you are, a lot of our older adults, they actually have that fear and that incredible trepidation for walking. Maybe even it's just outside on dry pavement, or just getting outside of the comfort of their home, or maybe it's somebody who's spending all day long in a recliner and just walking around their home. We'll talk a little bit about some of the factors in the home that can contribute to falls, but something like that, but the cycle of the more fearful you are and the less you're moving, the more likely you are to just stay still. Your muscles get tight, your joints tighten up, you are going to lose muscle strength. So all of those physical components are then going to play into, you're going to be more likely to fall. So it's a vicious cycle that kind of a long explanation for why fear of falling is actually contributes to people falling more. So what I'm going to do now is talk a little bit about 2 different types of factors that increase your likelihood of falling, the intrinsic and the extrinsic risk factors. So we are going to look at things that are internal. Right here, this little diagram will show you all the different little things we're going to talk about. And then there's the external that we'll talk about in a minute. And then just some strategies for prevention for these falls. Any questions yet from anyone? All right, so with intrinsic risk factors, we have different components there's 3 major components for balance that are internal. So this would be your inner ear, your vision, and proprioception. I'm going to talk about what proprioception means in a minute for those of you that might be a newer concept. But with inner ear, If you're somebody who has vestibular problems, maybe they complaining of dizziness, it can just be a little bit of lightheadedness, or the room might actually be spinning on you. Obviously, it's going to be hard to walk and keep your balance when your world is moving. And then also just in itself, like actual hearing loss can be a factor with falling. So when someone has hearing loss, they're using a lot more energy just paying attention to their environment. They're paying attention to a conversation on the other side of the room, and they're not able to completely focus on the uneven surfaces that they're hitting as they're changing a threshold and walking into another room. So those who have hearing loss actually have an increased risk of falling. The next one I'm going to talk about, vision, that's a little bit more common sense. You can kind of think, well, of course you're going to fall if you can't see very well, but people forget often that the hearing is actually also tied into someone's balance. So with vision, the obvious, like I just mentioned, if you can't see something and the obstacle that you're going to trip over and cause a fall that way. But also there are many different conditions that happen as people age that maybe cataracts, glaucoma, macular degeneration, changes that occur with diabetes, and many of these different conditions cause low vision, and people have more difficulty with judging their environment. Perhaps it takes more time for them to adjust to entering a room that's brighter, or it doesn't even have to be going outside. It can be going into a dark room. Just the natural adjustment that eyes undergo as you go into spaces with different amounts of light, it takes a little bit longer. So that can be, and that is a normal part of aging, just the eyes take longer to adjust with changes in light. And then also a glare factor, depending on what's going on with your eye, there could be that glare. So those types of things obviously will impact your balance, as in addition to changes in depth perception. Let me say that again. Depth perception can be a problem with judging maybe that last step. You think you're on the last step, but there's one more to go, and things like that can cause falls. So, and then with proprioception, that it's a fancy word for just basically saying that your mind knows where your body is in space. So if you close your eyes, I know my hand is in front of me in a fist, but somebody that has proprioception difficulties that can be caused by different medical conditions, neuropathy, or maybe after a stroke, those not knowing where your foot is, or if your ankle is turned, or you can't feel there's a big crack in the sidewalk. Those kind of things obviously can contribute to falls as well. So also, let's talk about some extrinsic risk factors with falling. So with the extrinsic risk factors, we're talking about things that are outside of your body processes. So in looking at this picture here, it's almost like one of those, how many things do you see that could cause someone to fall in this picture? So obviously environmental space makes a huge difference in someone's, increasing someone's risk of falling. So for example, if you look at this picture, the clutter, the not having much space to walk around the furniture, having objects on the floor, having cords right under your chair where you could trip. The area rug in itself is a tripping hazard. So all of these different types of things are going to increase someone's risk of falling. So the other thing to consider when you're looking at this picture, not only just the furniture and the things that might get in your way, is the lighting. And you're, considering, well, the shades are drawn, there's one lamp, I don't know if there's overhead lighting. But the different types of lighting that you have in a home can also be a factor with increasing your risk of falling or not. So we'll talk in a minute about just different ways that we can help remove some of these obstacles to make it less likely for us to falling. The other thing with extrinsic factors to mention, a big one is medications. So a lot of how many of your medications that you're taking, say right on the bottle may cause dizziness, right? So that's something to consider, that depending on what kind of medications you're on, you might have an increased likelihood of falling just based on you're a little bit, lightheaded. Oftentimes medications can cause something called orthostatic hypotension. It's a big word for your blood pressure is going to drop when you stand up, or maybe you're lying down and you go to sitting, but postural changes affect your blood pressure. So with that, people that have this, maybe they don't even realize it, but their blood pressure is dropping 10 or more points when they change positions, which can cause that kind of lightheaded feeling, and people are falling when they're getting out of bed or just even standing up from a chair. So the use of more than four or more medications every day actually doubles the risk of falls. So evidence shows the polypharmacy, when you're on multiple medications, just the interactions with those and the different reasons you're on them, that in itself is increasing a risk factor. And there's the obvious of, certain medications, especially those if they're sleep aids, have that kind of hangover effect where people, helps them sleep, but it definitely has a risk for increasing the risk of falling for a certain amount of time after you take those. So, all right, so preventing falls. So kind of the big, talked about all the reasons why people are falling. So now what do we do to prevent that? So that's where there's a lot you can do just on your own. Just look around your house and modify that environment. Take up those area rugs. If you've hit your toe on it, as you're walking by, chances are that's going to be a pattern, and area rugs in general are beautiful, but they are definitely increasing your risk. So just clearing the clutter, making things that you use, keeping objects that you use frequently at your, take them out of those really high cupboards or those really low ones and put them where you can reach things. And just making the environment user-friendly in that way. Footwear, we didn't really talk about that as being a risk, but making sure that what you're wearing on your feet is rubber sole, good, supportive, not slippery. Lots of people trip when they have on kind of slippers that aren't really on their foot very well. Might be comfortable and keep your house clean, but not so great for walking around the home. And if you're diabetic, of course, having a really good pair of custom-made diabetic shoes to help protect your skin and offer that support as well. So then going back to some of the intrinsic risk factors and what do you do? Those are part of your body. Like how can you help reduce your risk of falling if you have some of these issues? So with hearing and with any of these, first thing, visit your physician, visit your primary care provider. They're going to help identify if you have some of these risk factors. They're going to be doing medication management and reviewing what you're taking to make sure that you're on what you need to be without increasing your risk of falling. The ear, obviously, visit your ENT. Physical therapists can also help with vestibular problems. If you have positional changes and vestibular problem, that can be something a physical therapist can address. But addressing, seeing the right providers to help you with all of the issues with your vision and your hearing. Other things for vision is using the daylight light bulbs. I have them in this room behind me. not necessarily to help me not fall, but keeps me awake and happy when I'm working. Sometimes bright lights in your environment really do make a big impact. So kind of take a look around where you spend a lot of your time and brighten it up a bit, especially if you if you know somebody who's tending to stumble. Maybe it's just a matter of lighting. Maybe you need to add a different type of, a brighter light, the daylight, and or motion sensor night lights can be really helpful as well. Especially if someone gets up at night to use the bathroom, it's great to have that pathway lit, and there's those motion sensor ones, so they don't have to be on all night, but as soon as you get up and start moving, they can come on, and that can really help people too. And with so we kind of mentioned the blood pressure, the medication, just being aware if you're, having a medical professional take your blood pressure when you're sitting and when you're standing, or when you're lying and then go to sitting. And if you're at all thinking you might have that orthostatic hypotension, it'd be good to get that evaluated, because that can definitely increase your risk of falling. And removing obstacles. So also bathrooms. I mean, I said the majority of falls do not happen in the bathroom, but a lot of them do, because for obvious reasons. There's wet, slippery surfaces, and people get up and use it and they're tired and not fully awake. But having adaptive equipment like grab bars and the correct kind of transfer benches and shower chairs, all of those things can help decrease risk of falling in the bathroom. And then just making sure that you have the right covering on the floor so that it's not slippery, but it's also not something that you're going to trip on. And let's see. So also with all of this, the last obvious, we talked about environmental modifications there. We have the grab bars and the handheld sprayer for the shower and the lighting on the steps. But lastly, just the role of therapy, PT, OT, and actually speech too, can all help reduce falling. So that occupational therapists can come in and do a home safety assessment and give you lots of recommendations for making your home environment safer, and also helping you with adaptive equipment and just making things much more just safe in your home environment and keeping you strong as well. And then also the role of, can't talk about prevention of falls, especially in my field with physical therapy, without talking about the role of balance training. So lots of evidence out there to show the power behind doing balance training. So a lot of studies are showing that it takes about 150 hours of training to make a significant impact on reducing your risk of falling. But that can, it sounds like a huge number, but it's actually little by little, and doing home things. And it's just a matter of kind of helping your body adjust to postural changes. We call it like developing riding reactions and learning ankle strategies, and actually increasing your strength in your legs. Like all of this helps play into reducing your risk of falling. So physical therapists will, first off, every evaluation, PT and OT, there is a balance assessment component where we do what we call functional objective measures. So we run people through a few standardized tests that are evidence-based, that show your likelihood of falling based on what you score on these tests. So after that, then we would develop a customized plan of care that would, vary according to what each individual's impairments are, and to help someone really, really improve their actual standing balance, so that when they encounter different situations, they're able to quickly right themselves instead of falling if it's a balance impairment. So that's all I have in the presentation. We can open it up now if anyone has questions, but again, just a really important topic, and a lot of this common sense, but sometimes it helps to be reminded of common sense things. And I, again, just thank CarePatrol for inviting me.
Great. Thank you, Theresa. You know, when you are going to a client's house now, I know the world is a different place, but I love that photograph that you had of the living room there, and all of these hazards. And I think so often, you know, somebody may have a fall, and then they go to the hospital, and they may be getting rehab there to the hospital and discharged back home, or maybe it's a move from, you know, the hospital to a skilled nursing community, and then, you know, back home or to assisted living. But what I'm always struck by is that so many of us want to remain at home, but our homes are not medical facilities, and they present a lot of hazards, both physical and from a cleanliness point of view as well. You know, so the thing that jumped out at me that gets me all the time, and I've got to remove it from my house, is the glass coffee table. You know, and sort of talking about vision and not being able to see clearly defined borders it results in some serious injuries when you bump your leg against a coffee table, or you miss that last step because you've got the nice white carpet going up and down the stairs.
Yeah, that's a really good point. And I think those of us who don't have visual impairment, we kind of take for granted that, like, for example, I have a patient I see who, she has a very large finished basement, and we practice walking with her rollator. And in this finished basement are these very large columns. You know, they're squared off and there's drywall, but it's, you know, like any basement with like the support columns, but they're the exact same color as the walls around, and happen to be the carpet as well. So I can't tell you how many times she almost, or has, like, bumped into it with her walker, because she doesn't even see it. It's like it doesn't exist because everything's so monochromatic. So I've actually, you know, part of the strategy is like putting, well, this time of year you can put garland around it, or, you know, but the daughter doesn't want to make her home unsightly, but there's strategies to like hang a picture on that column or something to make it stand out. So yeah, you're right. Like the glass coffee table are things that we think, oh, well, of course I see it, but maybe someone with some visual impairment doesn't.
Yeah. Now, Charles asks a really good question. Does hearing impairment directly affect balance?
It does. Yeah. There are a lot of studies out there that are showing that people with hearing loss do fall more. And it's the rationale is, I think it is more of like the energy involved in multitasking, and they're not picking up the cues from the environment as much. But I know somebody who is basically, well, she has cochlear implants now, but she's been basically kind of almost deaf her whole life. And she said as a kid, she fell constantly. You know, it's just not hearing things. And then their energy is so much used up just by communicating that they're not paying attention and not able to multitask and notice a step that's there or something.
Let's see. And then also, Charles asks, is there any one particular place in the home where you've sort of found falls most occur?
So it's usually near the bed or in the bathroom, I find. I mean, occasionally in the kitchen, but I find, somewhere bed, bathroom, because if you think about it, that's where, if someone's not very mobile, those are where they're transferring a lot. Everyone's getting in and out of bed or on and off the commode. So those two places are often the biggest culprits. But the evidence does show it's in the home while someone's doing normal activities. So
Yeah.
not necessarily anywhere else.
Well, one of the things about the bedroom, especially at night, is having proper lighting. And there's some really good solutions that are out there now where you can attach sensors to like the baseboard of a bed, so that when somebody puts their foot down, the lights pop on. You know, for 2021, the CarePatrol follow-up might be some of the easy, low-cost solutions that we can do to our homes that can also prevent falls. Let's see. Bonnie asks, what types of meds are most likely to contribute to fall risk? Do you have any sort of guidelines there?
Well, medications for depression, sleep, hypertension, and other heart problems, those are the ones that are most likely at risk of causing the orthostatic hypotension. So increase your risk of falling basically every time you get up if it's a quick positional change. So the sleep aids like Ambien, those are also like a known, the amount of falls if someone's on those increases a lot. So those categories are typically anything that's going to adjust your blood pressure, heart rate, or help you sleep, and where there's that lethargy, hangover, carryover, those are the ones that are most likely. But there can be combinations of other types that can also do those things. So that's where it's helpful just to get a medication reconciliation done by a healthcare provider, just to make sure that nothing you're on is interacting in a way that's going to increase the risk of falling. And then
Cynthia,
Steve, to go along with what you said before, like when you had mentioned the lighting, something now that's very simple that a lot of people have is they can hook up like Alexa or the Google to their lights. So, you know, if someone's not able to physically turn on the light, or you have to get out of bed to do so, which is obviously you're going to fall, if you know, that's what we're working on. You could just say, hey, Google, turn on the lights. And that's been a great way that people can, if they have to get up and go to the bathroom, they just shout out to Google, turn on the lights, and then they can have them Google turn off the lights when they get back into bed. That's been a nice little technology advance.
Yeah, and you know, I think you can still also order the clapper where you clap on, clap off. So
Okay, right.
if you don't have Google,
Nice.
order your loved one the clapper.
Perfect.
Let's see. The really good question here from Cynthia, who says, I'm curious about your experience with people who have hip surgery after a fall when they have osteoporosis and the success rate of operation and recovery.
Yeah, so thanks for Cynthia for bringing up osteoporosis. So osteoporosis by itself does not influence your risk of falling, but it does significantly increase your risk of fractures if you fall. So 25% of people with those hip fractures that we talked about die within a year, but 60% of those have a definite impact and function in their life. So osteoporosis is something, and that honestly, there are, we call them pathological fractures, where that, and it probably fits into that 30% of all fractures that are all falls that are unpreventable. So with someone with severe osteoporosis, and, you know, there's the fracture that happens and then the fall. So it's, you know, it's kind of sad, but it does happen in people with those really brittle bones where they could just be standing and they have their hip fracture, which causes them to fall. So, so with any kind of osteoporosis, exercise is key in the rehab, whether it's pre or post, hopefully pre-fall, pre-fracture, but if it happens to be afterwards, getting the muscles really strong around those joints and to help support those bones is crucial. I don't know if that answered your question.
Well, Yeah, no, I thought that was really good. And one of the things, I don't know, when I was reading Cynthia's question, that, I know a lot of times people are in the hospital and they're faced with the choice, like their doctor gives them a choice. Let's say it's a hip or a knee. It's sort of like, well, you can go home and do rehab, outpatient or what have you, or you can go to a skilled nursing center and receive your rehab. And, have you, do you have any thoughts on those two different choices? I know I regularly get calls from people that are like, there's no way I'm going to a rehab facility but however, their provider says, look, if you go here for a couple of weeks, you're gonna ensure that you're gonna get a healthy rehab plan. And any sort of thoughts on that?
So there's no like cookie cutter answer to that. Every person and their situation is so variable. What might be best for one person after a knee replacement maybe wouldn't be best for others. I know there's a lot of people on this call that could probably argue either way, depending on what setting they're in. But I mean, we see all, all ends of that spectrum. I could argue either way, but I guess it does come down to the family, and they're making that best kind of learning all the facts and then putting them together. So when you go into skilled nursing, obviously it's often an extension of your Medicare aid benefits that you pay for, and it's covered, and you get more intensive therapy there. So I mean, depending on, I know other people might argue now with the COVID environment, are you putting yourself more at risk? But, I guess that depends on where you go. And then there's other people that they're fairly, they don't have a lot of comorbidities. They had a joint replaced and they're fairly healthy. Their rehab, maybe they don't need to go into a skilled facility. They're perfectly fine having home health, and then maybe outpatient on wheels, or go to an outpatient clinic or whatever to continue that way too. So I don't really have a standard, this is always best or this is always best, because it kind of
Yeah,
is very variable.
thank you. And I was more sort of throwing that out as this is a natural question that comes up, and people are oftentimes
Yeah.
torn with that decision. But you
Mm-hmm.
reiterated that everybody is different, and so often you will talk to somebody who maybe had a hip replacement and they went to a rehab center, and they're going to say, "Oh, you got to go to a rehab center." And then you talk to somebody else who's like, "Well, I did it at home and it was great,"
Mm-hmm.
So I was just sort of throwing that out. Glenda asks, what is SLP? Does it have to do with
Oh,
speech
good.
language therapy?
It does. Thank you. Yeah. So speech language pathologist.
Okay.
So it's the clinician that helps with anything to do with obviously speech, swallowing, or cognitive therapy.
And another person typed into chat, and this sort of is in alignment with what the question that I just posed is, did you mention small bathrooms and not having walk-in showers? I think these are things that every individual needs to consider when sort of looking at their situation. Is their setting conducive to living a purposeful life and minimizing risk? I think many of us live in homes that have hazardous bathrooms, and tubs and tripping hazards and things of that nature. And that's one thing, because those could end up landing us in the hospital. But then if we're in the hospital and returning home, are we going to be able to recuperate and get back to normal with the setting in our home?
Mm-hmm. And that's where we work a lot with the different resources out there to help modify homes. OTs can make suggestions, but they can't obviously convert bathtubs into showers and things. But they, maybe they just need a transfer bench to make it more safe with a handheld shower hose. But yeah, you're right. Like my own home, I have to either go up 6 steps or down 6 steps to get to a bathroom. So in 30 years, will I want to do that? I don't know.
And there's a comment that I did reference these motion lights for under the bed. I posted a link to just one. I'm not endorsing this product, but if you go on under Amazon and you just type in motion lights under bed, you'll come up with some choices there. And what's neat about it is these motion lights could also be used under your kitchen cabinetry or in a bathroom, and you just wave your hand instead of having to turn on a light switch. And the beauty, like Theresa said, if you've got Alexa or Google, you can now easily, just by simply replacing your light bulbs and connecting them to your smart device, have voice controls for just about everything. Let's see. And I did see there was a comment about sort of the banter and chat. One of the things that I wanted to just point out is that the audience for this is a wide cross section of older adults, family members, and providers. And I don't want you to think anybody introducing themselves in chat is as a commercial. Just consider it a resource, because we're all here to help each other. And so we've got some great experienced professionals in the audience that might be able to help you, along with the CarePatrol team and Theresa. Let's see, Charles says, if there is an individual who's a designated fall risk and they insist on continuing to live in their home alone, what do you think about a paid call-in service that checks in on the individual by phone several times during the day? Any thoughts on that, Theresa?
I mean, it sounds like, because that does happen, right? Like everyone has freedom, and what we might think is safe or not safe, they ultimately might just choose, well, I don't really care, I'm going to stay here. So anything we can do to help augment their situation and give them support, whether it's an obvious like lifeline where they push it if they would need help and fall. Yeah, I'm not familiar with the call-in service, so that would be great to hear about. So I don't know. Do they carry a phone on them that they answer, or do they walk to the phone? Or I mean, there's so many great.
The Maryland Department of Aging actually has a call-in service that they launched this year, and it's called the Senior Call Check Program, and I'm adding a link to it in chat. But I believe there's a similar program in DC and Virginia. So that I think one of the things that is that people need to recognize is that when you are rehabbing or living at home, it takes a little bit of creativity. But as we've just referenced on this call, there's a lot of different services and things like that that can help facilitate people rehabbing or aging in place at home safely. The benefit, albeit there are downsides, the benefit of sort of doing rehab or moving to an assisted living or skilled nursing or something like that is it's more of a turnkey setup. And with that, Theresa, I did want to just ask you, I'm familiar that Fox Rehab, you guys actually provide rehabs. You have like rehab centers that are located in many senior living communities throughout the country, correct?
Correct. We were built on the house call model, but we are primary care providers in many senior living communities in the area. So we have a gym in those communities, and we provide the med-beast, therapy for the residents in those communities. So,
and the benefit of that in these communities is that, you've now got, instead of that community having to sort of either have multifunctional staff that provide the rehab or going out and hiring, folks, is that they can sort of tap into the entire Fox Rehabilitation network and have your experts there, and not necessarily
right.
have to be a 40-hour-a-week employee at that community.
Right, absolutely. And in fact, in one of the senior living communities in the footprint that I oversee, we rolled out just a few months ago it's called Fox Stronger Living, and it's a comprehensive wellness program that the senior living community actually invests in. So it's at no additional cost to the residents, and it's actually, it doesn't go through their insurance. It's paid for by the senior living community. But what it is, it's a very comprehensive wellness program where an exercise physiologist that is employed by Fox, we run this program, and we have a portal where we do kind of wellness assessments on every single resident in the community, and then tailor classes according to the functional level that they're in. So it's a great resource for the residents in that community. So we're excited to have that offered.
Great. Well, once again, these hours go by really quick. So what I was going to do here to just sort of close out our session today is bring the CarePatrol team back on to wave goodbye to everybody, and maybe any additional closing. Oh, shoot. Sorry, I just stopped somebody's video. Any closing thoughts, share any closing thoughts. And I recorded this conversation, so we'll be able to share it for future folks that weren't able to tune in.
So one closing cost, Theresa, it was great today. I thought the most positive thing you said is 2/3 of all falls can be preventive. So I guess it gives me a lot of solace that things like, in services like this can help. The other thing that I'm finding with seniors is we're all wearing masks, and I'm dating myself right now, but I find I have trouble walking sometimes because I wear glasses, I have a mask on, my hair's in my face. So I have been really very considerate when I'm walking with a senior who's wearing a mask, that I have to be more cautious than I normally am.
That's a good point. Absolutely.
Well, great, guys.
Especially stairs, right?
Yeah, going downstairs.
I know, with a mask. Yeah, it's hard.
Well, great, folks. I think this is somebody, Isabel says glasses fogging up with a mask. That is a safety hazard. I think we can all attest to that. And that's one that didn't exist a year ago. Judy says the handrail. Yeah, Bonnie says bifocals. No, this is great.
Have you heard about the dish soap? That's like the best. So we all wear goggles or face shields on top of the mask when we're treating. And if you use dish soap, like Joy dish soap, and rub it inside your glasses or shield or whatever, and then rinse it off and just let it like pat it or air dry, something about the chemistry and their surfactant, it won't fog up. So you can give it a try with your glasses. I actually haven't, and I usually wear glasses, so I don't know. But thank you, Steve. You've been a great host.
It was a great presentation.
Yeah, no, this really was. And hats off to the CarePatrol team for putting together such a great speaker series here in this crazy year. But I'm really excited to hear what is what you guys have in store for 2021. And I also just want to remind the audience, especially those who are professionals in the audience, about the CarePatrol CEU event that's going to be held tomorrow on medical ethics and advanced care planning. So with that, if do you say we can wrap this up?
Yep. Take care. Bye, everyone.
All right.
Bye, everybody.
Holidays.
See you,
Thank you.
everybody.
Thanks.
Okay.
Bye.